في الاول كل الشكر لاساتذتنا دكتور محمد عامر، دكتور برعي، دكتور محمد نجيب، طبعا دكتوره بسمه، دكتور محمد عبد الغني بس هو مش موجود، على الفرصه دي. و let's roll on.
7 minutes التايمر بعد اذنك.
اوكي.
7 دقايق التايمر.
Our case we call the plot twist. She is a 22-year-old female patient presented to us complaining of 2 days of disturbed conscious level. She had a history of 10 days of jaundice and sore throat and fever of 2 weeks. She had a C-section from 4 months, and she had a 10-day course of Augmentin following her fever and sore throat. On examination, the patient was slightly confused. She had dysarthritic speech. She had flapping tremors and jaundice. She had skin exfoliations involving both her hands and feet and the median malleus and both lips. Her vitals, what was abnormal, her temperature. She was slightly feverish, 38°.8. This is the pattern of skin exfoliations involved in this patient. Her regional examination was unremarkable. Her abdominal ultrasound showed the evidence of acute hepatitis in the form of thick-walled gallbladder. Otherwise, it was normal. Okay, up to now it's obvious. A case of acute fulminant hepatitis, mostly drug-induced, as the patient had Augmentin following her fever. Her labs showed a pattern of normocytic normochromic anemia. Hemoglobin level was 8.8. She had normal leukocytic and platelet count, but unexpectedly, her INR was normal. Her acute phase reactant were positive. Her liver function tests showed a pattern of cholestatic hepatitis. Of course, the panel of acute hepatitis was made. Her viral markers were negative. Her autoimmune markers showed positive NA, but the others were negative. Okay, now we have to think outside the box. This is not a straightforward case of acute fulminant hepatitis. She may be evenly not acute fulminant hepatitis. She had a normal INR. Okay, she's jaundiced, she's disturbed, but her INR was normal. So let's revise. The first question, does the patient actually disturb? Does she actually have flapping tremors? Let's revise. Okay, apparently, this is not flapping tremors. This patient had chorea. This is a pattern of chorea. This is not flapping tremors. So, we thought we got it. The patient has liver affection. She has neurological affection. She must have Wilson's disease. Let's do the panel. We had CT and MRI, which were normal. EEG showed abnormal pattern without definite diagnosis. The fourth pattern of Wilson was done. Unfortunately, it was normal. The patient didn't have Wilson disease. Okay. Second question, could it be autoimmune and drug-induced hepatitis? Okay, it's not a case of acute fulminant hepatitis, it's a case of hepatitis. Okay, what may be the cause of hepatitis? A 3-day follow-up of her liver function showed completely normal liver function. After 3 days, the patient is still feverish, the patient still has those movements, she now has a normal liver function. So, the liver here is not the primary organ of involvement. The liver is secondary involved in this case. Let's continue. Skin lesions. What could be the cause of skin lesion? We have a wide differential diagnosis for the causes of exfoliative dermatitis. What was treatable in this case is the Stevens-Johnson syndrome. Drug-induced affection and beta-lactam drugs. She had Augmentin. Beta-lactam drugs were recorded to cause such condition. Okay, let's go back for the differential diagnosis of chorea. This patient has chorea. We have to move on the pathway of chorea. Metabolic disorders excluded in the case of Wilson's. The first and second possibilities we had, first was rheumatic fever. We all know chorea is a common presentation of rheumatic fever, so it may be rheumatic fever. This is a revised Jones criteria for the diagnosis of rheumatic fever. The patient had chorea, which is a major criterion. We had made an echo. Echo showed minimal pericardial effusion, so she had pericarditis, 2 major. Up to now, they are enough to diagnose. Also, she has minor criteria. She had fever and positive acute phase reactant. So we moved on the pathway that the patient had rheumatic fever. Small note, the patient had normal ASOT. We give a 1-week history of high-dose aspirin as recommended by cardiology. Neurology recommended valproic acid for her choreal movement, but it is hepatotoxic, so we avoided it. After 1 week, the patient is improved. Again, another thing is wrong. The patient is not improving. What could it be? This is the criteria for the diagnosis of systemic lupus. We had seen the differential diagnosis is wide. One of it was the autoimmune conditions, just like systemic lupus, antiphospholipid syndrome. The panel of systemic lupus was done. We remember the patient had positive ANA, pericardial effusion. The patient would be diagnosed as systemic lupus if she had 10 points, but 2 of them must be clinical. So the patient has clinically fever, which is 2 points, and the other tests were done, low serum complement C3 and C4, they take 4 points. Positive lupus anticoagulant for diagnosis of antiphospholipid syndrome, 2 points, and Coombs test was positive. The patient, we remember, had a normocytic normochromic anemia. Patient started low-dose steroid, Imuran and hydroxychloroquine, and she was improved dramatically. So, spotted in a nutshell, 22-year-old female patient presented with acute cholestatic hepatitis, Stevens-Johnson syndrome, mostly drug-induced. The hepatitis resolved after stoppage of drug, so it's mostly drug-induced, and the skin affection was mostly drug-induced. She had fever and chorea. We diagnosed it systemic lupus, and secondary antiphospholipid syndrome. She had positive lupus anticoagulant, and she improved on treatment. Our messages. The first message, fever is not a sign of antibiotic deficiency. We see here, antibiotic given to the patient changed totally the disease course. The patient, we thought she had liver affection. She didn't have liver affection. The drug-induced liver affection changed our thinking in this case. So do not give antibiotics unless you know the cause of fever. Secondly, never deceive yourself with the diagnosis. Ask a colleague instead. We convinced ourselves that this is a case of rheumatic fever. This was not true. We went in that pathway. We treated it without improvement. Lastly, chorea may be the presentation of systemic lupus, and thank you.
شكرا جزيلا دكتور يوسف. طبعا يعني حالة